Good morning to those remotely connected. We will be starting the meeting in a few minutes. Thank you.
Call the meeting to order. Before I get started, I am not Lyndon Taylor, but I am sitting in for him in person to chair the meeting, though it looks like Lyndon may be on joining us virtually. So will the secretary please call the roll?
Director Bott is absent. Director Burnett Ziegler? Here. Director Garza?
Present.
Director Green? Oh, she stepped away. Director Harrington?
Present.
Director Kim? Present. Director Lowry?
Present. I have a new title. Thank you.
Director Robinson is absent. Director Sorrell is absent. Director Webster Cross? Present. Chair Taylor?
Present.
Thank you. And Acting Chair Ryder?
Ryder is here. All right. I would like to first entertain a motion to allow Chair Taylor to remotely participate in the meeting as a voting member.
So moved.
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye. Aye.
Opposed? The ayes have it. And it looks like Dr. Green just came back, so we'll note that she is present for the record. The next regular meeting, first I want to welcome our three new board members. Dr. Burnett Ziegler, filling Brother Curry's vacancy, and Dr. Maya Green, President Practical Direct Appointment to the board. So thank you for joining us and being part of the fun.
Thank you.
And, I, of course, would like to, welcome our other new, board member who was approved by the county yesterday.
Yes.
My good friend and, ally and everything having to do with, fighting for the residents of Cook County. And I gotta be honest with you, I know a very good, close, friend, of our former, Vice Chair, Dennis Deere, Commissioner Bill Lowry. Thank you.
Thank you, Bob.
For
Thank
your
you.
service, Bill.
Thank you.
The next regular meeting of the board is scheduled for Friday, November 22nd at 9 a.m. I believe we are going first employee recognition, which is going to be reviewed by our, hang on. We also have something else new today.
A lot of change.
It's not called out in the script, but maybe it is later.
I might have taken the interim off out.
You did that. That's what jumped out of me. We used to have an interim, up until recently, an interim chief executive officer. Now we have a chief executive officer. So first, congratulations to Dr.
Here, here. Here, here.
You're our first person for employee recognition. All right. Well, let's
All right.
recognize all of our hardworking, rank and file, staff and managers.
Absolutely. Well, thank you, Acting Chair Ryder, and good morning, directors. We want to start by recognizing our new hires, starting with Julie Mudge, Senior Director of APRN, Tanisha Rattler, Manager of Operations, Community Health Center, Englewood Health Center, John Barcinas, Manager of Operations, Multi-Specialty Practice, Orthopedics Clinic, Jessica Roberson, Prior Authorization Manager, Finance Revenue Cycle, Alex Achilles, Nurse Coordinator 2, CERMAC Health Services, and Latosha Gordon, House Administrator. Moving to the next slide, we want to recognize our team members who've earned promotions over the last month. Evan Greenbaum, Chair of the Division of Otolaryngology Surgery, Mohammed Sohel Ahmed, Medical Director, Neuroscience Service Line, Marcy Ellerman, Senior Director of Long-Term Services and Supports, County Care, Sarah Elder, Director of Recovery Support Services, CCH Behavioral Health Authority, Blanca Lopez, Director, Integrated Social Services Program, Core Administration, Jaron Tasnim, Enrollment Retention Manager, County Care, Cortisha Montgomery, Medical Staff Credentialing Manager, and Queenie Mendanka, Business Manager 3, Anesthesia and Pain Service Administration. And we'll shift to some recognition, celebration.
Let's give a round of applause.
Oh, sure. All right, and we'll shift to some recognitions and celebrations. Happy to share that on October 1st, we hosted a pivotal behavioral health workforce symposium, which focused on the urgent need to address workforce shortages in the mental health space. Symposium was coordinated by the Office of Behavioral Health and the Cook County Department of Public Health, and centered around key findings from the newly released Cook County Behavioral Health Workforce Report. It was a really great event. Congratulations to both teams. Thank you for your support. Next slide. On October 15th, we were very excited to announce the launch of a new tool that's helping us diagnose lung cancer, which is the leading cause of cancer deaths in the United States. It's the Intuitive Surgical Ion Navigational Bronchoscopy Platform. It's a cutting-edge tool that helps us diagnose lung cancer in a safer, quicker, and more accurate manner. And it was a big lift, and congratulations to the multidisciplinary team that was involved. And again, as always, if you're here, please stand so we can recognize you. And just earlier this week, we shared an announcement around the placement of vending machines at our Cook County Health facilities for Narcan. We're including the Cook County jail waiting rooms as well as Cook County courthouses, which will dispense Narcan free of charge. We had 3 installed in September, and across those 3, we've already dispensed more than 750 doses. Next slide. Cook County Health's ACHN site earned Silver Target BP recognition from the American Medical Association and the American Heart Association in recognition for their commitment to improving blood pressure control through accurate measurement in adult patients. Congratulations, team. We want to recognize Donica Austin Cathy, who I think is here with us. Hi, Donica. Our chief. our Chief Hospital Executive for Stroger Hospital. She was appointed to the Volunteer Metropolitan Chicago Board of Directors for the American Heart Association. Congratulations, Donica. We also want to recognize our Cook County Department of Public Health team for recently being awarded 2 awards. The Here to Hear You video campaign, which received an Award of Excellence at the Public Relations Society of America, the Chicago Skyline Awards in the Best Use of Broadcast Film Video category, as well as the Publicity Club of Chicago's Golden Trumpet Award in the video category. The campaign featured recorded conversations of Black and Hispanic males on the topic of suicide prevention and mental health. Congratulations, team. Congratulations as well to Ann Sikora Jackson. Is she here with us? Oh, okay. Senior Director of Advanced Practice Providers. She won the Physician Assistant of the Region Award from the Illinois Academy of Physician Assistants. The award is bestowed to an advanced practice provider who's demonstrated exceptional dedication, commitment, and outstanding contributions to the medical community. Congratulations, Ann. Congrats as well to Chrissy Torino, Chief Plan Officer, Medicaid Services, for being selected to join the Carol Emmett Fellowship Class of 2025. The Carol Emmett Fellowship is a program of the Carol Emmett Foundation, which accelerates the leadership capacity and national visibility of women in health. Congratulations, Chrissy. We also celebrated Hispanic Heritage Month. We led a discussion on Facebook Live in Spanish to reach out to our Spanish-speaking patients on the role of Hispanic culture plays in overall health. The event earned more than 31,000, almost 32,000 impressions, and over 17,000 engagements on social media. And thank you to Shannon Andrews, Maria Castillo, Maritza Guzman Loriano, Jaime Martinez, Dr. Juan Pablo Ruiz, and Hilda Salgado for a successful and insightful event. I think that's it, so we'll pause there and I'll give it back to you, Acting Chair Ryder. Thank you.
Yeah, thank you, Eric. Next on the agenda is public testimony. Debbie, do we have anyone registered to provide in-person or virtual oral testimony, or written testimony that is to be included in the record?
We have 1 registration for oral testimony, Domenica Flanagan.
Please.
Just a reminder, you have 3 minutes. When you have 1 minute left, I'll give you a quick heads up.
Good morning.
Good morning.
My name is Domenica Flanagan, and I am a SANE nurse speaking on behalf of the Cook County Health SANE Nurses and National Nurses United National Nurses Organizing Committee. 6 months ago, I had the opportunity to speak to the board about the prevalence of sexual violence and the overwhelming need for SANE nurses to care for victims of sexual violence and their families. The board's response was immediate. Shortly after I finished speaking, Chief Compliance and Privacy Officer Nicole Almiro approached me, and a few days later, I had the privilege of meeting with her and Associate Chief Nurse Executive for Ambulatory Services, Dr. Elizabeth Vaklovic. That meeting sparked significant movement towards a solution, and my hope was renewed for the first time since December 2022. Though it was not my intention, Nicole and Elizabeth discovered then that I'm the pediatric SANE covering all of Cook County Health, and subsequently an executive order was given to my director, Dr. William McCracken, to not call me if I take time off. A few months later, 2 children under the age of 10 presented to Stroger for care after being sexually assaulted, and I was not called due to that executive order. When I found out what happened, I was absolutely devastated. I understand that the executive order was born out of compassion towards me, but it was never going to work as intended, because I know what it is like to be sexually victimized as a child and never receive care. And so I would rather have to respond 24/7, 365 than fail another child ever again. Today, I remain the only pediatric SANE covering all of Cook County Health. Agency SANEs care almost entirely for our adult adolescent volumes, which have grown significantly, and Cook County Health has yet to set a date to meet with NNOC for impact bargaining. I understand that the hospital's resources are not endless and that equitable resource allocation is one of your most challenging tasks. Give me 1 hour. I can show you the devastating impact that sexual violence has on victims, their families, and their communities, and why we should support SANEs, and how SANE's extensive training and excruciating work drastically differentiates them from all other nurses, even the ones who are on call. If the board members are as exceptional and compassionate as Chief Compliance and Privacy Officer Nicole Almiro or Associate CNE Dr. Elizabeth Vaklovic, I have hoped that the board will ensure CCH sets a close date for impact bargaining with NNOC soon. I also hope that you will take me up on my offer to show you why addressing sexual violence with SANEs is so important. Saints are vital to the health of victims, their families, and communities, and Saints will not be able to manage the severe strain and permanent ramifications of their work if they are not appropriately compensated. Thank you.
Thank you. All right. Next on the, and by the way, we'll take your comments and discuss with the CEO and hopefully address this very important issue that you brought up. Thank you. Next we have a resolution. So today, as we announced earlier, we have a number of new board members that are being seated, and that means that we have people that are moving on, who have served us well, and have been strong advocates for the system. And the person that we have that's rolling off the board today is Bob Curry, and thank you for sitting at the table. You were trying to hide in. I just want to first go to the resolution, and then I want to move towards comments from our other board members and to our CEO. Cook County Health Board of Directors resolution recognizing Robert Curry. Whereas Robert Curry was appointed by Cook County Board President Tony Preckwinkle and approved by the Cook County Board of Commissioners to serve as the Director of the Cook County Health and Hospital Systems Board effective September 24th, 2020. Whereas Director Curry has been a valued member of the Cook County Health Board of Directors, bringing extensive expertise in healthcare administration to the health system's governing body. And whereas he has served on several board committees, Managed Care and Human Resources, as well as the CEO Search Special Committee, and whereas he served as chair of the Managed Care Committee from 2022 to 2024, and whereas he regularly advocated for initiatives that promoted health equity in the historic mission of Cook County Health, and whereas Director Curry provided exemplary guidance to Cook County Health in the midst of the COVID-19 pandemic that strained healthcare organizations across the globe, and whereas during this service he has shown a tremendous dedication to Cook County Health, the residents of Cook County, and the pursuit of health equity, and now therefore be it resolved that the members of the Cook County Health Board of Directors express their thanks and gratitude to Robert Curry for his hard work and dedication to Cook County Health and his service to the patients we serve. And upon execution, this would be approved by the Cook County Board of Directors on October 25th, 2024. First, I want to thank Bob for coming in to receive this recognition. And I would ask that there is a motion to approve item 4, the proposed resolution honoring the service of Director Robert Curry.
So moved.
Second.
A motion has been made and properly seconded, and now we're going to be on discussion of the resolution. So I would first make some introductory comments and then proceed to Chair Taylor if he is still on for comments as well. Bob, you came onto this board during the pandemic when we were all looking at people in small pictures on Microsoft Teams meetings, and I remember our first in-person meeting. I remarked to myself two things. Bob Curry is as tall and as big as I expected him to be, and Joe Harrington was shorter than I thought he was. But I also appreciate, someone who's been on this board a long time and who, takes the mission of the hospital to the community and to its employees, needs to do it seriously. I appreciate, your support that you've given during chaotic times during a lot of transition. You came onto the board after we had hired a new CEO that you didn't have any visibility into, because we had just concluded the search before you then hired Israel before you came on the board. But you jumped in and helped support a very changing environment. The health system prior to the pandemic faced a number of institutional, structural, financial challenges, and you've been there for the rebuilding of it, and that's oftentimes the most critical part, because you get to come in with fresh eyes and help us create an environment that supports the mission. And we're not done. We've looked at a lot of issues that we still need to tackle with the things that we'll be talking about later. But you've also been an advocate on those issues with many of you on our overutilization of agency workers and how we transition that, but also those important issues of equity and structure and governance and everything else that goes into this. So I just want to thank you for your support for the health system and for your friendship. And if you don't have my personal contact information, I'll certainly get it to you. All right. Anything I can do to help. And I'm going to go to Lyndon, and I don't know why I'm looking at the screen, because it's not like that's him. So, but Lyndon, if you're there, I don't know if you
I'm here. Can you?
We can hear you.
I am here. So it's okay. Look at the screen, Bob. I feel like you're looking at me, so it's okay. We appreciate it. But Director Curry, first I will echo everything that Director Ryder said, and I will lead with thank you. I reflect back when I came onto the board as a chair, the first call I got was from you. I do remember that. And I will say thank you, because you've always been there with a word of advice. You've always said yes when asked to go the extra mile, be it be on the committee, show up for a meeting, chair a committee, and quite frankly, you chair one of our most important committees as we've both moved to fiscal discipline and sound financial footing. And we know that you now are going to go out and maybe enjoy, hopefully, the next chapter in your life, and we wish you the best. So thank you.
One thing that I neglected to mention, a lot of this came up when Dennis passed away. Life happened to you during your service on this board, like it has to many other people. So your participation while life was happening to you is greatly appreciated. Do we have any comments from any other directors? Joe?
Yeah, I want to thank you as well. We've known each other for a number of years. I don't know how many years, but I know it's been a long time. We probably met each other early in our careers. And I've had the opportunity to work with you off and on, particularly through the National Association of Health Services Executives, the local chapter, which you've been very active in and involved in nationally. But I'm going to miss you as a member of this board. But I do have your phone number. I know where you live, and you can rest assured that we will be talking beyond this. But thank you. You did an excellent job, and we will miss you.
Thank you, Joe. Director Garza.
Thank you. Thank you, Chair Ryder. So yeah, I always knew of you, and then we finally had a chance to meet several years ago, and I just want to say thank you for your compassion, your passion, and the technical expertise that you brought to the board, and really teaching me quite a bit about a lot of those technical parts of the work that we're doing as a board member. So really enjoyed my time with you. Thank you, brother.
Do we have any?
I also, too, just want to thank you for your time here on the board and your support for me. Since I've been on the board, too, just want to wish you well. Take care.
Bill?
Thank you. So, Bob, this is, it's obvious that we have not served together on this board, but I have certainly admired your work, And I thank you for everything you've done for this board and just for Cook County Health, but also thank you for always showing up at Providence. As many of you know, I served the 3rd District as Commissioner. Providence is one of our gyms, but it's been wonderful having your support, having you model just service right there in the community. So I appreciate that. And I'll close by saying, like you, my favorite color is black.
Any other comments from directors? If not, I'm going to go to our CEO, Eric Makaitis.
Thank you very much, Bob. You know, on behalf of the health system, I just want to say thank you for your participation, your guidance on this board. You know, I wasn't around for the whole time, but you know, we went through some difficult times with you know, during your tenure, and I have no doubt that your participation, your leadership helped get us through it. So, thank you for that. On a personal note, I want to say I'm going to miss our conversations around payer innovations, and yeah, it's been really great having you as a sounding board in that arena, and as well, thank you for your work on the search committee. I appreciate your input there, and I hope we can keep in touch.
Thank you.
All right. Are there any other comments? Hearing none, we have a resolution that has been properly moved and seconded. All those in favor signify by saying aye.
Aye.
Opposed?
Aye.
Opposed? The ayes have it. So we're going to take a moment. We have a, do you need this copy or you have one there? I have one. Sure. Now we go into the traditional presentation of the resolution and the picture of Old County Hospital. Yeah, we're gonna just take one moment. Alex, is this area here fine? You have a gigantic setting for piece of the entire wall, so.
All right, we might need to make a layer of those, so someone to
The key is to pivot your body at 45 to 30 degrees.
keep it around.
Oh, yeah.
All right, 1, 2, 3. Thank you so much.
The other, if you're at a press conference, you want to be on camera, you stay right, position yourself right over the shoulder of the speaker. I don't think anybody found that funny other than Bill.
I thought it was good.
Bob, we'd like to hear from you now.
Thank you. First, I'd like to say from the bottom of my heart, this has been an honor, I give this and a privilege to serve this community, all the residents of Cook County, all of our patients, and every individual that we served over these 4 years. For me, it's special because I landed in Cook County, of all places, when I left home some 50 years ago, in 1970, actually 54 years ago. This was the first new place I'd ever come to. So there was a special attachment. Spent my career in healthcare. And so central to that career, learning, growing, building relationships, service. A lot of it started right here at the old Cook County Hospital. What was then, back in the 70s, the Governing Commission that was responsible for the governance and provision of services. As I went on my career, I went a lot of different directions. But when I received the call and an invitation 4 years ago to have the opportunity to come home and to spend some time here in the central of one of the worst healthcare calamities that we ever had, that pandemic. The team that was put together, this board, supported by the commission, supported by President Preckwinkle, put our nose to the grindstones and did everything that we needed to do to put our arms around residents of this county. And let me tell each and every one of you here, the staff, the support, my fellow board members, you made a difference. You saved a lot of lives. And we have more work to do going forward, and I'm confident and excited knowing that we will achieve these successes. Thank you again for letting me be just a small part of this road together. It's something I will take with me for the rest of my life. So with that, I'm going to slide off the board. I can count off and X out the 4th Friday every month. I'm secretly waiting. And again, it's not goodbye. I know we'll continue staying in touch, communicating, and my service does not end with anything that I can do to assist you and walk with you to continue to move our mission forward. I will. Thank you all.
One thing that you missed out on, Bob, and I did too, because right before I got here on this board, they used to meet at 7:30. So just imagine that. Every other week, yeah. Thank you so much. So the board meetings were 5 hours too. Just like to note for the record that Director Bott is connected remotely. Do we need to do a yeah. So if I can have another motion to allow Director Bott to remotely participate in the meeting as a voting member.
So moved.
Motion's been made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye. Aye.
Opposed?
Aye.
All right. Moving on, we now are going to go to our board and committee reports. These are, the first we have the September 27th, 2024 board meeting minutes. These are being presented for the board's approval. Are there any corrections that need to be made to the minutes? Any corrections? Any corrections? Is there a motion to approve item 5A, the September 27th board meeting minutes?
I'll make the motion.
Motion's been made. Is there a second?
Second.
Motion's been made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
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 Opposed?
Aye.
The ayes have it. Next, we have, the, audit and compliance meeting minutes from October 18th, 2024, and they will be reviewed by Director Harrington.
Thank you. The Audit and Compliance Committee met on Friday, October 18th at 9 a.m. The Audit and Compliance Committee's regular meeting schedule for 2025 has not been determined. However, it is expected that the committee will begin holding their quarterly meetings starting in January of 2025. Nicole Amero, Chief Corporate Compliance Officer, reviewed the report, which included information on the following subjects: Compliance Program Overview, Review and Approve Audit and Compliance Committee Charter, Metrics, Systems Compliance, County Care Medicaid Health Plan Compliance Program Recoveries. The committee recommended approval of the proposed Audit and Compliance Committee of the Board of Directors Charter. Committee did go into closed session, receive a closed meeting report, receive a review of that report in closed session later in this meeting. Because there are no action items associated with closed session, the minutes can be approved at this time.
Is there a motion to approve item 5B, the October 18, 2024 Audit and Compliance Committee meeting minutes?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed?
Aye.
You guys have it. We are going to also now go to the other meeting that occurred that day, the October 18th Managed Care Committee meeting minutes, which will also be reviewed by Director Harrington.
The Managed Care Committee met on Friday, October the 18th at 10:30 a.m. The Managed Care Committee's regular meeting schedule for 2025 has not yet been determined. However, it is expected that the committee will begin holding their quarterly meetings starting in January of 2025. The committee reviewed and discussed the report, which included information on the following subjects. Health plan successes include their improved 2024 NCQA health plan ratings, recognition from the award, with an award from, for public excellence, the county care, baby shower. We were very happy to know that they did that and actually had pictures, and their participation in the Bud Billiken Parade. We also had pictures of that. They reported on quality metrics from the National Committee for Quality Assurance, the Health Choice Report Card, which showed health plans compare for their services and their plans for improving quality, strategy, and strategic initiatives and priorities as well. The Health Choice Illinois RFP timing and listening sessions were among the things discussed. Redetermination outcomes and redetermination events, provider network enhancements, non-emergency medical transition, and the 1115 waiver. During the discussion of telehealth initiatives, a question was raised regarding the number of urgent care conditions that would be served under virtual care strategy. Angela O'Bannon, Chief Information Officer, replied that the list includes 20 or so conditions and stated that they could provide an exact list. Are there any questions?
Does anyone have any questions for Director Harrington on the minutes?
If there are no questions, approval of minutes can take place at this time.
All right. Is there a motion to approve item 5C, the October 18th Managed Care Committee meeting minutes?
So moved.
So moved.
Motion's been made. Is there a second? Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. I will be providing the next report on the October 17th, 2024 Finance Committee meeting minutes. The Finance Committee met on Thursday, October 17th at 10 a.m. The next meeting of the committee will be held on Thursday, November 14th at 9 a.m. We are not planning to have staff review reports and contracts from the meeting. While you are reviewing the minutes, Deb has a slide reflected with a list of contractual requests greater than $1 million. If there are any questions on any of these requests, Charles, Pam, and staff are present and ready to address. The committee considered the following action items, which are included in the minutes. We conditionally approved 37 contract and procurement items. Number 16, 21, 22, 24, 30, 31, 34, and 35 are pending review by contract compliance. On the screen, you'll see the contractual requests on the Finance Committee's fiscal impacts are greater than $1 million, as I said earlier, which are highlighted for your information. With regard to the request pertaining to community health workers, among the Cook County Department of Health related requests under item 4A, contracts procurement items, Director Harrington requested a summary of the number of workers and where they are working. We also received and filed grant award related items and transfer of funds. I would also note during the review of those contract items, we had another discussion over our usage of agency and how we are going to continue to retire some of the usage of agency, and we will be having a report on that later in the presentation from the CEO. We also committed to having a monthly report on agency utilization in the Finance Committee, which will at least initially be reflected in this first report. So the first report, after today, the first report on agency utilization that will occur will happen at the Finance Committee on November 14th. We received and filed grant award related items and transfer of funds. The committee received the following reports, which are also included in the minutes. the fiscal year 2024 quarter 3 report of contracts executed under the authority of the CEO, report of the August 2024 financials, and an update on our revenue cycle transformation. If there are no other questions, the minutes are being presented for the board's approval at this time. Is there a motion to approve item 5D, the October 17th, 2024 Finance Committee meeting minutes? Sure.
So there are a couple of services related to COVID-19 services. What are those specifically?
Are you talking about under the contract and procurement items? Which request numbers? And I'll have, Charles take a look at it and respond. Under public health?
2, 6, 7, 9.
So if I can have, Charles and Dr. Hasbrook come up to the table. Looks like that. Charles, Dr. Hasbrook's gonna handle it.
Thank you for the question. So yeah, those are all no-cost extensions for about 9 or so grant awards that we're getting from CDC. They're all directed towards COVID recovery for communities hardest hit, and they all relate to our community health worker or community health promoter program. So it really is about training a cadre of community health workers and placing them in the community. So it's a no-cost extension, no additional fiscal impact.
Thank you.
Thank you.
Thank you, Dr. Hasbrook. I made the motion already, right?
You called the question. I don't know if you make motions.
Oh. Is there a motion? Motion's been made. Motion's been made by Director Harrington.
I'll second.
Second from Director Garza. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed?
Aye.
The ayes have it. All right. We're now moving to action items under 6A, contract and procurement items. There are none being presented directly to the board for consideration. We have a proposed Stroger Hospital Department Division Chair initial appointments, reappointments item that's being presented by Dr. Claudia Fegan, our Chief Medical Officer. So it looks like we have 3 items under this, four appointments.
Good morning, directors.
Good morning.
Claudia Fegan, Chief Medical Officer for Cook County Health. Just for information for the new directors, we have established a process where, all the positions are re-credentialed on a regular cycle. So when physicians who are in leadership positions are up for their regular medical staff reappointment, we also bring to the board their appointments as department or division chairs. The first person is Dr. Chun Feng. Chun Feng has been appointed as the chair of the Department of Radiology. She will be overseeing the quality of radiologic services for patients and provide administrative leadership and support to the COO of hospital services and to the Chief Medical Officer and CEO. In addition, she will lead the strategic plan for the department, ensuring coordination and compatibility with CCH's strategic plan. She earned her medical degree from Northwestern University Feinberg School of Medicine. She completed her internship at the University of Chicago in radiology and a fellowship in body imaging, both Northwestern and McGaw's Medical Center. And she was originally appointed as interim chair of radiology in November of 2023 and has now been designated for the permanent position. The next reappointment is Fred Starr, Chair Division of Trauma Administration. Has been reappointed as Trauma Administration and Burn Services. He graduated from Thomas Jefferson University Medical College. He completed his general surgery residency in 2004 at Rush University, his trauma fellowship in 2005, and Surgical Critical Care Fellowship in 2006 here at Stroger. He's board certified in general surgery and surgical critical care. He serves as the director and instructor for advanced surgical skills for exposure and trauma, or ASSET course, and is an instructor for definitive surgical trauma care course. He is the Cook County Health Physician and lead for the Health Systems Military Civilian Partnership with the U.S. Navy. He served as the interim chair for trauma from June of 2023 until April of 2024, when we appointed Dr. Mallory Williams. The next person is Tarlin Hadiyeti, who is the chair of the Division of Emergency Medicine Education. She has been appointed as the chair of Emergency Medicine Education. She graduated from the University of Chicago Medical School, where she did her internship in the Department of Anesthesia and a residency at the University of Southern California in the Department of Emergency Medicine. She's pursuing her Master's of Education at Johns Hopkins School of Education in Baltimore currently. And the last one is Dr. Peter Hart, who's been appointed as the chair of the Department of Medicine. He earned his medical degree from the University of Lagos and did his residency here at Cook County. Dr. Hart is focused on high-quality patient care, teaching, and research in all aspects of adult nephrology, and will focus on the management and prevention of progressive diabetic and hypertensive chronic kidney disease. He was originally appointed as the chair of the Department of Medicine in February of 2023. I'll answer any questions about any of the candidates. Thank you.
Any questions for Dr. Fegan? Hearing none, is there a motion to approve item 6B, 1 department chair initial appointment, 1 department chair reappointment, and 2 division chair reappointments?
So moved.
A motion's been made. Is there a second? Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
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 Opposed? Ayes have it.
Thank you very much.
So slowing down to catch the delay. All right. Next up, proposed Stroger Hospital and Provident Hospital medical staff appointments, reappointment, changes presented for consideration, being presented by Dr. Akintoran and Dr. Allegretti. These were sent in advance of the meeting for director's review and have gone through the established credentialing process.
And Dr. Akintoran is remote.
All right. Dr. Akintoran?
Yes, good morning. Good morning, Director Ryder and all the directors. I'm presenting to you the Executive Medical Staff Committee of Australia, Junior Hospital of Cook County Health, approved list of medical staff action items. These were approved at the meeting of EMS on October 8, 2024. Presenting this to you for your consideration today. These are medical staff appointments, reappointments, and other changes. Thank you.
Thank you, Dr. Akintoran. Is there any questions for him on his items before we move to Dr. Allegretti? No. Dr. Allegretti?
Good morning, everybody.
Good morning.
Paul Allegretti, medical staff president in Provident. The credentials meeting for Provident met on September 24th, 2024, and those meeting minutes were approved on October 4th at the Med Exec for Provident, and we presented them to you for approval here. So I'm here for any questions.
Are there any questions for Dr. Allegretti? Hearing none, thank you, Dr. Allegretti. So I am now looking for a motion to approve item 6C, the Stroger Hospital and Provident Hospital medical staff appointments, reappointments, changes.
I'll make a motion.
Motion's been made by Director Garza. Is there a second? Second. Second's been made by Director Mia Webster Cross. Is there any discussion on the motion? Hearing none, all those in favor signify by saying aye.
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 Opposed? The ayes have it. All right. Any items listed under? Skip D, right? Oh, that's next, yeah. I was just,
It was a supplemental item, which is why it's so weird.
I was just looking to see if there's anything under D.
Sorry.
Next up, we have a proposed resolution regarding agency usage and the strategies that will be implemented to reduce such, introduced by Acting Chair Ryder. We've had a number of discussions around the utilization of agency here at this board. Most of the discussion has occurred in the Finance Committee, where we review agency contracts. We've asked a number of questions over the years. Specifically, it's been ramping up. We've heard a lot from the labor unions that represent our employees over the usage of nurse registry and other agency, specifically NNOC, representatives from ASME Council 31 and SEIU Local 73. We took a report within the last 3-4 months around our usage of nurse registry and agency utilization. What that report told us was that, and we've had this report specifically on registry a couple times, that we are heading into positive territory as it relates to meeting our attrition and exceeding our attrition rate. So which is ultimately what impacts our filling of vacancies and the reduction of reliance on nurse agency. We've crossed that threshold of being in positive territory. We are not on the precipice of filling all the nurse vacancies, so I don't want to overstate where we're at. One thing that's become, as we tackle that issue, the staff has been ramping up, looking at our agency utilization. And when we talk about agency, we're talking about, similar to nurse registry, our reliance on staffing agency support in order to fill positions that are either where we have vacancies or where we've had to surge past our available positions. We have, and I think this was noted last week at the Finance Committee and in previous discussions, we have places where we have the positions filled, but then we're also on top of that, utilizing agency. And part of the challenge that we also have is we have approximately, and Eric's going to go over some of this stuff again, but I feel like I need to make sure everybody knows that I'm well educated on this. We have about 2,000 vacancies. The county has asked that we not increase those vacancies or add any other positions until we show progress in reducing those vacancies. So what ends up happening is that in places where we are, where we need growth and we're supplementing with agencies, we haven't increased the position count in those because of the way we have to keep shuffling around positions. I just think that it's also worth noting that we don't have that the bucket of positions isn't like, we have all these positions for nursing and it's just it's not one classification of nursing or one classification of EVS or one classification for different tech positions. There's subcategories of those positions. So you have to, as you have needs that are taking priority within the vacancies, you have to move things around. As we have an area where we're fully staff according to the budget, but now we're also having agency. At some point, we need to move or move positions into that to create vacancies to hire into as we make improvements, or we have to get to a point where we're going to be able to create new positions for those vacancies to create a pathway for employee hires. I'm gonna pause right here because I think I want to have the if we can go out of order a little bit before we pass this motion and fully explain the motion. I think it's appropriate to get the context behind all that, so around where we're at and where we plan on going. So I'm going to ask the board secretary to bear with me because I'm doing this out of order, and I'm going to go to Dr. McKitis there. Can we jump into this right now?
Absolutely, yeah. Let's go for it. So Andrea, we'll come back to you at the end of the report for the strategic update. Okay. Yeah.
You were hoping to get out of here before that. I'm sorry.
So we'll start in the middle. We're also going to do an employee engagement survey update. That'll be kind of the third piece that we'll talk about. And just for reference, the proposed resolution language, I think, is in page 75 in your packet. Okay, so staffing and agency, thank you, Acting Chair Ryder, for that, for setting the stage. Let's go into current state. So you covered a lot of this, Bob, but you know, right now, all in system-wide, we're at 18% agency utilization, which is just a pure, you know, math problem of how many budgeted positions do we have and how much agency are we using across the entire system. There are, as Acting Chair Ryder mentioned, several departments and roles that have utilization way above 18%. We're going to dive into some of those in just a minute. You know, as I know this board's aware that we had some challenges with hiring and recruiting, both from kind of the national workforce setting as well as some opportunities in terms of our internal processes and how we onboard and recruit. And one of the things that has proved a challenge in, you know, the last, I guess, several years of our using agency has been that there's really kind of been this opportunity to be more transparent and have a more overarching control of how we're using agency. It has historically been very departmentally focused, where a manager director can pick up and call and bring in more folks, and it's kind of led to a lot of kind of siloed use of agency. So the last few months has been an exercise in kind of corralling that and having system level transparency in terms of what's happening. A significant contributor, unfortunately, has been kind of that unexpected use of FMLA and having to backfill when employees use that. And Carrie and team looked at what our current state is, and in the past, actually, as a typo, in the past 16 months, we've had almost 1,230 employees take at least one day of FMLA. So, you know, obviously causes unexpected gaps in our staffing. Some of the good news, as I said, we're going to do a deeper dive into employee engagement, but we're seeing some positive movement. We've, in 2022, we were in the 7th percentile for our employee feedback in terms of engagement. That has moved up to the 21st percentile. And as I always say, well, I'm not going to spike the ball on 21st percentile. I think it's a very nice trend. I know Prescani was very surprised to see that much of a jump in 2 years. Additionally, we're seeing turnover rates improving. We currently sit between 7 and 8% of a turnover rate, and national averages are usually around the 20% range. So we're hopeful that as we kind of stop the bleeding on the back end and we're able to be more efficient and able to hire more efficiently, that we'll start to kind of fill up again. And again, as Acting Chair Ryder mentioned, we've seen improvements in the net hires year over year. I think that's actually on the next slide. Yeah, so this is the typical, one of our typical HR data slides. So you can see here, this is through the end of September. And actually, while I'm going through this, if I could ask Carrie and Craig to kind of come up for any discussion that might come at the end of this. So you can see we've extended 1,662 offers. We've had just over 1,000 accepted, 630 external hires, and at the same time had 417 separations, which actually puts us net positive. And then we have there for comparison, fiscal 23, we were at 211. So this is through the end of September. We have 2 more months to go. We're hoping we'll actually continue to outpace and do even better than last year. Just for reference, 23 was the first year since at least 2019 that we were actually net positive. We've lost people on balance 2019, 20, and 21, 22 as well. So 23, we finally flipped that to the positive, and we're on a good trend now as well. So we're hopeful that that continues. All that said, 2 to 250 a year isn't going to fill the bucket. We still have to, continue to accelerate. So this next slide is going to be new, and this will be a work in progress, and I think we'll be expanding on this as well, probably a discussion at finance in terms of what would be meaningful in terms of tracking and presenting. So in September, for the year-to-date average FTEs per month used of agency, we're at 1,345. So that means we had 1,345 FTE on average per month working in the hospital, all in across all departments. And you can see some of the more challenging departments on the right there, and that's the splits. The yellow section of the bar is filled positions, and the blue is agency average. So you can see EVS, laboratory, even nursing, proving to be a bigger challenge there in terms of filled versus agency, and we'll do a numeric kind of dive in. And at the bottom left, there's been a lot of discussion around what language we might be able to adapt in the EP, and we'll come to that in the employment plan. We'll come to that in kind of next steps, but we'll start filling that in as we're able to start converting and moving agency folks into CCH employed positions. So that'll be another data point in the bottom left there as we begin that work. Next slide. So we'll jump into the numbers. There's some nursing numbers across different roles under nursing. You can see starting left to right, we have budgeted FTE, so those are the number of positions we have. Filled is the next column, followed by vacant FTE. So we have our vacancy rate there as the first percentage, and then for comparison, agency FTE. Now, Dr. Peters has done a very nice job in ensuring that we stay under the 1-to-1 in terms of not having more agency than we have positions. But you can see there still agency rate remains a challenge in terms of how much, especially in the clinical nurse team. And here are the other departments. So we have that stacked by agency rate, and as Acting Chair Ryder mentioned, we have some challenges there. Those top 4 or 5 are very high utilization. And the agency to PID gap, it's the second column from the right, is what he was talking about, where I call it being upside down in those departments where we're using more agency than we have positions. So in other words, we don't have the positions to even fill. There's additional agency folks in those departments beyond what we're able to staff, were we able to fill completely. Next slide. So that's just a quick glance at contracted services. There's been a lot of, in the last few months, discussions around how we clarify what has strategically been outsourced as a complete service. And those are I think, all of the main examples of what has been the discussion. So something I think eventually that makes sense to look at, but right now we have this burning platform of right-sizing our departments and ensuring that we have the PIDs to staff into those on the previous slide. Next slide. So some action.
And there's one other thing that we should highlight. There's agency utilization, and then there's functions that we've historically subcontracted, right? So there are places where we have contracts with outside vendors that are providing a complete service, right? I think.
Yeah, that was that last slide.
That last slide.
Mm-hmm.
Those are generally were decisions that were made way back when, like the cleaning of our clinics is subcontracted, and that's been that way for years, for a while. So there could also be a discussion at some point about insourcing some of that. We've got to first get this under control before we do that, and that's actually not one of the things that's been brought up. I just flagged that as eventually that could be a place where you could also see some financial improvement down the road. So.
All right, thank you. So some of our current actions that we're working through, we've implemented a biweekly check-in with between Carrie, myself, and then our BHR partners at the county level, both BHR and labor. And then with the President's Chief of Staff, we're bringing together offices under the President counterparts with some of our CCH leadership teams on a quarterly meeting, which is more of a strategic discussion, but HR plays heavy in those discussions, as you might imagine. As I mentioned at the start, we've developed system-level oversight around agency utilization and have created a system-level approval workflow that doesn't allow kind of the department level to just call agency in for any staffing needs. We've also paused any new agency additions while we work through this. So we've kind of capped on that and are not bringing anything in right now. And then, well, it's kind of, so the system level approval, I spoke to that already. And then auditing through our recent utilization, this is kind of some side work that's happening with Tom Schrader and Nicole Almiro around validating what we're getting from the agencies and ensuring that we're actually receiving the services that we're paying for. And then completing a market analysis around multiple positions to assess pay rates. We found a mix. There's some that we are at market. There's a handful that we are below market. So exploring how we get right in terms of the pay rates for those positions. And then lastly, really working through our internal processes. Over the last year, there's been a lot of work around those internal processes and how we can improve them to better streamline how we're hiring. We're now looking at our employment plan policies. We had the nursing accelerated hiring process, so we're working to make that permanent. And we're also looking to start adding in additional departments, some of those more challenging ones that we spoke about earlier, EBS, food service, transporters. I think there's one more slide, Deb. Thank you. So some of the exercises we're going through right now, we have probably for the last, 9, 12 months had a benchmarking database that we're using now to really right-size the department. And the nice thing about that is it's by profession, by area of focus. They really use benchmarking metrics based on what the job is, right? So EVS has cleanable square footage. Food service might have meals delivered, right? So very kind of focused in terms of our size and our function. And then using percentiles to really try to target exactly what size that department should be based on our current state. So getting that right sizing exercise done, but then also locating currently vacant PIDs for reallocation to fix that upside down scenario in those 4 or 5 departments where we are, where we have more agency than we have positions. And at the same time, primarily Craig has taken the lead on this, but doing an exercise around just a 10% reduction across agency, especially in those departments where we're upside down. We're not talking about eliminating positions that we currently have in roles, but really kind of trimming the agency off the top. And then I think there's some operational efficiency opportunities here in terms of restructuring several of our shared roles that may live in different areas to bring them all under one umbrella. So I do really believe that there will be some economies of scale in doing a bit of a restructure there. And some early conversations now with our BHR partners is how we might work with our labor teams to potentially explore time limits on agency. So we can do this internally. What this is alluding to is that we would just put a cap on, if it's 9 months, 12 months, they can either choose to apply for employment or they'll be, they'll be canceled in terms of the contract for agency. Behind that, though, we are exploring the potential of working with our BHR partners in labor so that we can instead go to some type of a conversion discussion where potentially you hit this time limit and then we can just, it's available where we could work around the CBA and the EP policies to convert directly into an employed position. So more to come on that piece, but that's kind of a snapshot. Craig, Carrie, keep me honest. I don't know if there's anything else you guys want to add or if we want to pause for discussion.
I have questions.
Yeah.
No, right here.
Great.
No, okay. All right, a couple things if I could.
Bill, can I just jump in?
Please do. Please.
Real quick, just to further frame it out, and then we'll go to you first.
Perfect.
This discussion around agency utilization we've been having for some time. Go back and check the minutes of the Finance Committee, if we've been having it. Our employees who work in positions with high agency utilization are frustrated. We have to, we have to recognize that we are, we're not just a hospital, we're a public hospital, we're a government facility, and we have the opportunity, we have different goals, and we have different processes, and we have different values than even our private sector, not-for-profit hospitals that are research-based, that, have more fancy, shiny buildings and the way they invest in a lot in cloaking their not-for-profit status is by doing things that have community benefit, but not at the ground level, like Stroger, U of I, and our safety net hospitals. There's a difference between our safety net hospitals and other not-for-profit hospitals. Generally, all hospitals are not-for-profit, but we put them in different categories. Our employees are frustrated. Eric and I have talked about this. We have places where we have an extraordinary amount of agency utilization that even mid-tier private sector hospitals don't have. Like they wouldn't think about it other than maybe on the backfill of FMLA, but even then probably they're able to manage it with their existing staff. FMLA is a real thing, and I don't think anyone has an expectation that we would never have an agency contract. I believe during the pandemic, this problem got worse because there was cover for folks to go into it a little bit more, and we had expansion. And we even commented, there was a lot of cautions while we were going through that this couldn't get to a place where it was unmanageable and that there was a fear and anxiety that would happen. What I appreciate is the fact that the staff has been listening to this. Now, while we're having this discussion, some of our commissioners have also looked at this issue, and it's a concern to them as well. I would say the responsibility for managing and fixing this, though, lies with the health system, with the guidance, oversight, and direct involvement of this board to make it. We've made a lot of priorities over my time here, making sure that we could manage the budget, that we could, deploy programs during the pandemic, that we care for our communities. This is all tied into that. Our employees are community members. The morale of our employees and how that lands with the way the hospital operates has improved, as Eric noted, with our scores, and we need to keep that trend going. This will help improve those scores. We've been able to invest in staffing at certain levels. We've had more collaborative relationships with people. Getting people into positions and converting and finding a way to convert these agency people into regular employees will be morale boosting, will promote confidence, and will not undermine what our employee representatives are trying to do organizationally. So it's a good labor management practice as well. The resolution that we'll be discussing in a bit is a starting point. We're not passing a resolution today. We'll be referring a resolution to the Finance Committee so we can have this more discussion and have some inclusive conversations with our labor unions that represent our employees. We have some more briefings to do with a couple of it's always weird, I think, when I say labor partners, because I always thought that's a very corporate phrase. I'll use it, the labor partners. We'll have more conversation with them so we can get their input into what our plan is in terms of our benchmarking and things like that, because at the end of the day, the place where it matters the most is right here. This is our problem. This is our problem, our problem to fix, our challenge to meet. Bill?
Thank you, Bob. So just a couple of thoughts. I want us to be very purposeful and even being creative and out of the box if necessary, to come up with ways that I can really serve as a conduit as a director of this board and as a member of the Board of Commissioners. That's very important and it's very doable, but we need to put our heads together to come up with the best way to do it. This is an example of it. We do not benefit from the Board of Commissioners stepping into this space when you're already working in this space. So let's give thought to how we can process this going forward. So in addition to I'm talking now Board of Commissioner meetings, we have wonderful updates from CCH relative to a lot of different topics. But there might be an opportunity for me to give written updates to my colleagues on the board as we're waiting between these meetings. First of all, to just give information, which we all want to provide to them. But it may also keep some of my colleagues from going forward with resolutions that really might be premature given the work of this board and the jurisdiction of this board. So I want us to think about that. We've got, as you all know, we're in the budget process. Again, may be naive, but that's one of the beauties of joining a board. You come in and you have a lot of naive ideas and maybe one or two of them sticks, right? If we have a growth area and we're not raising our vacancies, is this an opportunity for me to present the amendment so we can reallocate some of those vacancies? At least let's have the conversation, all right? So I want to share that. The other thing I'd like to put out is as we go down this road, because this is something that everyone's talking about, agency. And what I noted is 18% of our workforce would be considered agency. Is that right? What is the national average in like systems? We need to know that, and we need to make that part of our narrative, especially if our 18 is below the average. All right? So much of this, you all know this, it's messaging. So big picture, I'm saying, let's be purposeful. Let's utilize in a way, my role here in a way, so I can provide information to my colleagues, which will really, I think, foster collaboration between the work of that board and the work of this one.
I appreciate that. And we have, that number reflects that in some areas, it's much lower than 18, but based on what we've seen, we're way higher in other areas. So we need to meet those benchmarks and exceed them. And in the areas where we're way behind, we need to get there. Because the number, there's different stories to be told under that number. Some of it is high functioning, some of it is needs great improvement. Now, I will say that we have to build trust. The commissioners have a role in our process. You guys, we bring our budgets to you, we report to you. We have the direct oversight. You guys, gave us the authority to do what we do here. Right? You passed the enabling ordinance, so we understand that there needs to continue to be a strong partnership between the hospital and the commissioners. But I do think that we have to be the ones that are accountable, and this is where the work's gonna get done. We also need to build trust with the people that work here at the hospital and their representatives. So I'm not just understanding of their frustration, I share it, right? I share it. What I think, because I've spent a lot of time advocating around this and a lot of time talking to Pam, Charles, and Eric about these issues. And, while everyone's frustrations were hitting a fever pitch, we were also having a parallel conversation about this being one of the first things that needs to be corrected. So we have to show people that we're in the game. Right. And that's part of the reason why the monthly Finance Committee metric report will be going, will, as always, be sent over to the commissioners as part of the report. You being a conduit to share information and to follow up with your colleagues is going to be critical to that. We also plan on, while all this is public information, we plan on making sure that we are sharing these reports with our partners, while at the same time actively engaging with them to help us resolve the problem. We heard one instance today where we did really well, but maybe had some unintended consequences, and we need to fix that. And the only way you can do that is by engaging in the conversation. So thank you for your comments, Commissioner. Joe?
Yeah, I just wanted to add some context to the resolution, because I just read it. I tried to read it carefully, but I want to start with some of my background. I worked at 3 different hospitals, community hospital, 2 academic medical centers, but most of my career was spent in public health. I worked for the city and state health departments. But the point that I really want to make is looking at this, we need to understand that healthcare is a big part. It's the largest part of what we do, but that's not all we do. We actually provide other services as well. We operate the core center, focused on HIV and AIDS. We also provide all health services for the Juvenile Detection Center in Cook County Jail. In addition to the fact that we have a public health department, and so we're involved in primary and secondary and tertiary prevention. So we're a very large system. Healthcare is the largest part of what we do, but it's not all we do. In reading the resolution, the wording that struck me most was in the second paragraph, where it says, whereas there are some dynamics in the world of healthcare that affect the ability of health systems, and we are health systems. And I wanted to look up the definition of dynamics. And dynamics is defined as characterized by constant change, activity, or progress. So we're exactly where we should be in some respects. And to that end, I want to commend our staff, our employees, and leadership for keeping this boat afloat during very difficult times.
Thank you, Joe. Any other comments from the commissioners? Or not from the commissioners? From the directors? Okay. So are we now to the point where we should,
We're referring to finance.
referring to the, is there a request for the, proposed resolution to be read? It's going to go to the finance committee, so we are not actually passing the resolution today, and this resolution may change before it comes back, to be considered by the board. So if there's no discussion, if there's no need, you all have printed copies of it. There's a need for me to read it, right?
And it's been posted to the website in advance.
Okay, all right. So, is there a motion to refer the proposed resolution regarding agency usage and the strategies that will be implemented to the finance committee?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
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 Opposed? The ayes have it. I just want to say that we've done a great job of making these meetings more efficient, because they used to be 4 to 5 hour meetings. And I feel like because we have some new members today, we had one member who rolled off, and we are presenting some real heady issues to everyone that I may not be asked back to chair the meeting. But if I get it done before 11, I think I'm fine. But all right. I am going to now, asking for a report from the chair. The only thing that I thank you, Carrie and Craig. And the reason, for anyone who questions, the reason why Craig's up here is that a lot of these departments that we have to work on are under report up through Craig, and Craig's done a great job, I think, of identifying and working with Eric on figuring this problem out. My report would be on the agency. It's what I've been occupying myself for a long time, and specifically, I've been spending a lot of time on it the last, probably month or two. So, I would now go to items under the Chief Executive Officer, Dr. Eric Macias.
All right. Thank you very much. We'll just keep rolling, and then Deb will back up to, yeah, okay. So employee engagement, as you are likely all aware, every 2 years, we have Press Ganey submit a survey out to all of our employees to complete a survey around their engagements and how they're feeling about working as part of our team. And here are the high-level results. And I think we have Ling on if there's any discussion. Wing, are you on?
Yes, I'm on.
Okay, wonderful, thank you. So here is the high-level summary. We hit a raw score of 3.84 out of 5, and you can see there on that, the circular color-coded diagram there, it's the split of highly engaged, engaged, neutral, and disengaged. So we have 10% of the team at disengaged, and the rest are somewhere between neutral and highly engaged. I'll call your attention to the bottom left, which is kind of a breakdown of period over period. So we had an increase of 0.23 points since 2022. That survey came in at a raw score of 3.61. And our Press Ganey partners, when they shared this with us, said that anything more than a 0.08 swing is statistically significant. So we're very excited to see that trend. It also moved us from the 7th percentile nationally up to the 21st percentile nationally with that move. And then you can see some more comparative information there. At the very bottom, we were somewhat encouraged by the response rate, which went from 48% all the way up to 57%, which is, I had done the math a few months ago. I think it was 500 or 600 additional people who had submitted the survey in response. And you can see it right there, the breakouts in terms of where we did well and where the opportunities are. And we'll kind of dig a little more into that as we move through the deck. Next slide, thank you. So these are the engagement-focused questions. There are a few more questions than this, but these are the top 6 that really show where we're at. Again, I would call your attention to the third column of numbers that shows kind of the delta period over period. You have there our percentile comparisons based on each question. But again, these are the top 6 drivers of likelihood of staying, how engaged the team members are. Next slide. This is a comparison to national average. So that yellow line at the bottom is where we were. So you can see in 2018, 5th percentile compared to US averages, 8th percentile in 2020. We dropped down to 7th, and the raw score took a bit of a dip in 22. But you see nationally, it also took a little dip there too, and remained relatively flat, where we gained a whole lot of ground going into 2024. So I would say I think this shows that we're catching up to where the national average is. Next slide. The breakdown.
This is peer performance. The other one. This is comparison to peer performance.
So that's the which the line? Yeah. So that's national healthcare average. So healthcare systems average is the blue line. Okay. So focusing in on facilities, these are kind of broken out by teams. You see County Care at the top with most engaged, followed by JTDC, Provident, Bureau. There's our average, so you can see above and below average. ACHN was just a little bit behind the overall average, and you can see the other teams there. Again, I would call out the rightmost column in terms of the swing. We've seen improvements almost entirely across the board. Next slide. And here is based on positions. You have senior management at the top, on through nursing and other team members, management, clerical, and so on. The middle line graph there is comparison to average. So where the red dots mean that we're below the national average, and the right column there is our comparison in terms of the delta from 22 to 24. So you can see green across the board and significance in most of the categories. I put a nice big red circle around nursing because we're actually better than national average there, which was very exciting to see. This was an interesting one. This was a breakdown by generation, and you can see a very linear trend where we have traditionalists being way above the system average, and as we go through the younger generations, we hit millennials or Generation Y, and they're the only ones that are below the average. Someone has to be below average, but I thought that linear nature was very interesting. At the same time, I would call out the delta period over period. While they were below average, they had the biggest increase across any of the generations. And I think we'll cover it when we get to kind of what we're doing about this in terms of moving forward, but really thinking. Yeah.
How's the survey delivered? Is it delivered electronically or paper?
Electronically.
So the older generation
think this is more of a commentary, and where I was going, was that we're gonna examine how we engage kind of the different generations based on what's, in terms of their workplace, work-life balance and all of that, but I think it's kind of the expectation now, with younger generations, right? There's a lot more remote opportunity, there's a lot, right? It's kind of different, and it becomes a challenge, I think, in healthcare, especially in kind of clinical roles, right? Where, you can't be a bedside nurse and have a remote day, right? Or at least not currently, right? But I think, kind of thinking about how we might engage differently, is I think it'd be a
Explained, you have highest percentage of, agency use in nursing, but then they have the highest engagement score. Do you think this is an accurate capture of what's going on?
I think it is, and I think it's statistically significant. I don't know that, I don't know that agency alone, I know we're unhappy about it across the board, right? We don't want agency, but I don't know that that's completely dissuaded people from finding kind of joy at work and being happy to be here and being engaged in terms of mission and what they do day in and day out. I think it's a challenge, it's a frustration for sure. But, I think Bina, her leadership team, they've done a lot of work around really trying to, move the needle on culture and engagement. There's been a lot of leadership development work, a lot of, seminars on innovation and all of those types of things that have really been focused in the nursing realm. So I think in that sense, I think there's been a lot of work done in the last few years to really try to engage the teams and show the opportunities and the engagement to really grow. So I think agency is a piece of it and certainly a driver of dissatisfaction, but I think there's been a lot of work outside of that that's really tried to move the needle in the right direction.
There's also the fact that this is generation. Each generation is different, very different, very unique.
Mm-hmm. All right. Deb, next slide. So this is a way of analyzing each question and helping us really kind of hone in on the pieces we need to focus on. So we create a quadrant by mapping our performance, the percentile rank on the y-axis against the impact. So what's most impactful and meaningful to our team members. So the top right is something that we've done well on, but is also very impactful. So we would continue promoting those. The high impact, low performance is the focus, the bottom right. So those are areas that really will help move the needle, but we did not perform very well on. And then the left side would be low impact, and then again, the same, right? So maintain the things that we're doing well but are low impact, and really kind of look at the things that are low impact and not performing well. So if we go to the next slide, you'll see where those questions fell out. I would really focus kind of the right side of the column where there's promote. So we did well with high quality care. We did well on being ethical, and then having confidence in management, leadership, and then areas we need to focus. Some of these were a little interesting was, so treating with respect, but then the job makes good use of my skills, and the job responsibilities, are clearly defined. So the second and third ones I thought were a little bit interesting in terms of job roles and utilizing skills and all of that. So we're planning to unpack that, and we'll kind of jump into where we're focusing in a slide or two, but those two, I think, need a little bit more of a deep dive. So these are the key drivers. Those are the 6 on the right side, promote and focus, and you can see kind of where the numbers fell out. Again, all but job responsibilities improved period over period, but, on the focus ones, we know we need to really drill in and do some work there. Next slide. This is the left side. So again, maintain is where we performed well, but it's low impact, and evaluate is where we didn't perform as well, and but still low impact units. Again, somewhat heartening that everything has improved period over period. So some next steps. Prescani is coming back. We're going to be doing 5 sessions at the department level. So they've come to present it to the senior leadership team, but they're going to be coming back to really do kind of a drill in on a department specific, how those departments performed and where those areas of opportunities are. So providing some guidance there to our managers and directors. We've launched high reliability work. So there's been 2 months now of training, and Steve Kreiser will be actually coming to present to all of you as part of the update next month. So we'll have some discussion around high reliability. We've implemented leader rounding. We've done 2 sessions now. It's every other Tuesday for 90 minutes. We all gather upstairs, and we kind of lay out a roadmap, a plan, and we break into groups of 2 or 3, and we kind of hit multiple departments and go and engage with the team members, really just to gauge kind of how they're doing, any concerns that they might have, give them kind of that opportunity to give some feedback. We're aiming for early 25 to open the wellness lounge downstairs. Ling did a really nice job taking some of kind of less utilized space right next to the cafeteria, where there'll be kind of a place to kind of unplug and take a bit of a break to get away from things for a few minutes during the workday. And then employee engagement committee, I think we have, where did the number go? I think it's 70% frontline. It is 70% frontline staff on this committee. It's all volunteer, but again, it's around working on appreciation and recognition initiatives. And then Ikigai and Schwartz rounds are ways of engaging to offer more transparency and an opportunity to allow our employees to really talk about kind of how they're doing, issues they've had, right? Schwartz rounds, we kind of, it's like a wellness check-in. And then Barrel Institute is another group. It's a system membership that's available to everyone, and there are there are resources and best practices within that we have access to. So I'm going to pause there. Ling, I don't know if you want to put a finer point on any of the next steps.
No, you did an amazing job. Thank you. But if, the directors have any questions, we're here to answer.
Okay, so we can pause for questions. Yes.
Thank you for that report. I'm wondering if we'll have our own metrics to see if these efforts are working outside of the press gaming surveys.
So we are planning kind of spot surveys. We haven't really figured out yet what that modality will be, if it's like a Survey Monkey or just kind of doing repeats through this kind of one-off. But yes, we are discussing how we do kind of a pulse check, essentially.
And additionally,
Yes,
it
so
seems that one of the, sorry.
I'm sorry,
ahead.
like in June and July of next year, we are doing a pulse survey with the 3 units that have the lowest scores, and also the 3 units that have the highest scores, just to see if it has improved for the lower scores, and then if it has been maintained for the higher scores. There is a platform that's called crowdsourcing, which we can use because it's a SSO, a single sign-on platform, where employees just need to punch in their email address and they can answer some questions. But we're using that platform concerning the one topic about being understanding your responsibility, whether it's clear for them or not. We could ask the employees to tell us, what does that look like for them? Does that mean, the managers need to review their job description with them yearly, or if at huddles, the managers need to direct them as to what they need to focus on that day. So, but we're allowing the employees to have that voice to tell us what that looks like to them, rather than us telling them what it means.
Okay. Any other questions?
I have a quick question. I saw their core center in Service Health Services has the lowest satisfaction. What do you think? I mean, Service, I guess I understand. What's going on with core center?
Yeah, there's been unfortunately a lot of change there in the last year. A lot of that's been driven by the unwinding with Hectone. There have been some leadership changes that have happened, and I think just a lot of tumult that we're going to have to really focus in on addressing and engaging the team on. If no other questions, Deb, maybe we'll rewind all the way to the top and have Andrea come up and give a strategic plan update.
Good morning, everyone. I guess I should have made the font bigger, but I'm the Chief Strategy Officer, and every month, thank you, Deb, we go over some of the things that have happened in the past month that are either accomplished or coming soon, that align with our strategic pillars. So we've talked about a few of these things already in this meeting, so I won't belabor those. But for some of the things that we've accomplished under our quality pillar, our Stroger Lab completed the American College of Pathologists survey. JTDC and CERMAC were both recognized for work related to suicide prevention and opioid work. The internal medicine residency and primary care residency achieved 100% American Board of Medicine pass rate. We've already mentioned the progress in the past month that we've made with the robotic bronchoscopy, so that's highlighted here. Under equity, I wanted to highlight that we've had a number of community fairs. We hosted a maternal child skills fair, a community baby shower that was mentioned already that County Care hosted at Provident, and first women's health fair with the General Medicine Clinic. In an earlier slide, we talked about the progress with the naloxone vending machines that are installed at Provident, Stroger, and Core. There's a third nursing cohort graduation from the residency program. There was a graduation for that group. County Care went live with the new provider directory. Public Health Department, the environmental unit, digitized some of their forms to improve service delivery. And under the growth pillar, speech pathology started performing outpatient video swallow studies, and also we expanded the hours for express care. So, sorry, Deb, I think I remember what's in the upper right. Okay. In terms of things that are coming soon, nursing is planning an innovation and research conference in January. County Care is meeting with Dominican University to educate staff who work with the students on how to enroll in Medicaid. There's a new dashboard being built that will be available next month on opioid use disorder. That's coming from collaboration with the opioid task force. The new sterile processing update at Provident should be completed in February. The centralized nurse triage and centralized scheduling model for OneSource Enterprise is also in the works. PTOT, who will be in the new Bronzeville Center, has finalized their contract for equipment, and that will be coming online in the coming months. Finalizing contracts, we've been working to finalize contracts with Express Scripts, who's the pharmacy benefits manager for Meridian and Blue Cross. We're required with those plans to contract with Express Scripts, and that allows us to be able to bill for some of the medication that we prescribe. So that has a value to us of about $3 to $4 million. So those are happening right now. So I'd be happy to answer any questions, or there's a room full of people who've been working on these initiatives, and I'm sure they could answer questions as well.
Any questions?
Okay. Thank you.
Thank you, Andrea.
Thank you, Andrea. Acting Chair Ryder, that concludes my report.
All right. We have a late arrival on public speaking that we're going to accommodate, but he walked out of the room unless he's just outside. So before we get to him, we'll take report from the Cook County Department of Health Public Health Quarterly Report, which is going to be reviewed by Dr. Lamar Hasbrook, our Chief Operating Officer in Public Health.
Thank you, Chair, and good morning to the directors, and welcome to the new directors. Looking forward to working with you all. So just by way of introduction, we are mandated to do a number of reports for the Cook County Board of Commissioners, Some are semi-annual, some are monthly, and some are quarterly. So we get to kind of choose what things we want to highlight. So today we're going to highlight public health data, equity, and improvement initiatives. Okay, so first slide, if we can go back to the first slide, I'll try to move through these pretty quickly. So just kind of framing the data and the health equity data. Obviously, the things in the box there in terms of race, ethnicity, gender identity, those things are characteristically captured. We also like to move into the areas of language preference and sexual orientation, disability status. Not quite there yet with all of our surveys. Obviously, if we're doing primary surveying, primary data collection, we have a little bit more control of that. And then we're looking at surveillance data by and large in terms of people, places, and time to help us better characterize the problem, obviously, to direct our resources and investments. Next slide. Ultimately, it's about enhancing a data-driven approach to the communities that we serve. So the next couple of slides just kind of highlight how we use data in this case, using our lead data in terms of the housing stock and where the lead problems are, where the kids are infected or affected by lead poisoning, doing door-to-door canvassing, and getting out into the community and helping them to understand the risk. Also, getting them to enroll in our lead abatement program where we do assessments and remediation, get the lead out of those houses as our resources will allow. Next. We also use the data to build community capacity. It's really about access to the data, use of the data for planning, for resource allocation, et cetera. So these are a couple of shots of us out in the community working with folks to actually help them understand how to access a data portal that we have called the Health Atlas, which I'll talk to you about in just a minute, and just helping them to actually be able to go and zoom down to data, the community level, the zip code level, to do their own planning and their own resource allocations and impacting the drivers of health and wellness in their community. Next. Give you a real life example of supporting community action. So in June and August, we used the data that we collected in collaboration with the Office of the Medical Examiner on overdose deaths, opioid overdose deaths. And you can see in the chart here, some of the communities or zip codes that had the highest number of deaths. A lot of this has been in the media recently. We've been working, and that's the naloxone recent initiative that you heard about at the top of this morning. So we actually focused in on Maywood, worked with the elected official there, the village mayor, and using this data, we were able to spend a kind of a day-long engagement, but over the course of 2 months to do a number of things. The day-long engagement included working with community-based organizations, faith-based organizations, school principals, and then in the upper right-hand corner there, you'll see about 100 folks identified as Black Men United, includes men and women. And they're the folks that are kind of paid community residents that kind of keep the streets safe, safe corridors for folks to go to school, come home from school, that kind of thing. So we trained them on the use of naloxone, distributed naloxone to them. We had local businesses, the picture in the bottom right, where we actually gave encased kind of plexiglass and encased supplies of naloxone or Narcan. I think each case had about 20 or 30. And these are for small businesses to actually keep at the business site behind the counter for folks in case they're needed. We had did a series of awareness education series over the last 2 months. So we're focusing on Cicero next. As you can see, Cicero had the top number of opioid-related deaths. And so again, a way to... Yes.
Lamar, who's the partner in Cicero? Are you working with the town or are you working with community organizations?
Both. Yeah, we try to get the elected and the community-based organizations, and oftentimes the elected officials and their teams will kind of help us to canvass and bring the key folks together. Great for us, yes. Next slide. So Commissioner Aguilar often asks, and several folks ask who are not very familiar with surveillance data, why does it take the data so long? Why is it a year? Why are we still working on 2022 data, et cetera? So we did kind of a deep dive with him, his staff, joined by our colleagues at IDPH, followed by Q&A, to really help them understand the different types of data that's collected. We like to categorize it as faster data and slower data, just kind of help him understand and others understand kind of the nuances around surveillance data. the bottom box there really tries to highlight the fact that the speed of public health data, regardless of the speed, that individuals receive timely diagnosis and treatment. That is, folks at the bedside, folks in the clinics, folks in the hospitals, you all may know, they're using that data, that lab result or that case identification right away. So it's not impacting that. It's great to have it in real time, but it's really about the surveillance data and watching the data over time and using that data to direct, again, allocation of resources, notices, public education, those types of things. Next slide. So there's a number of jurisdictional issues when we're talking about the slower data. For instance, here's an example. Most of the reportable disease conditions are reported by the residents of the person, and where the resident lives determines the jurisdiction, and the jurisdiction is covered by whatever local health department. There's about 100 in the state of Illinois. We serve suburban Cook County, but sometimes diseases are reported at the location of the provider. And so it has to kind of be disaggregated and really transferred from where they receive their care. They may live in suburban and come to Chicago and where they actually live. That adds time on data.
Lamar, can we, yes, Dr. Hansberg, can we highlight the suburban Cook County generally, but we have some other health departments that are in some of our municipalities that are, that have their own, including, other than Chicago.
Correct. So in suburban, there's about 2.5 million folks in suburban Cook County. We share that with 3 other smaller local health departments, Skokie, Stickney, and Evanston. And so we have about 2.3 or so million of that 2.5 million folks. And of course, Chicago, the city of Chicago takes care of the other 2.5 million in Cook County.
And do we have overlapping oversight, or do they have autonomy for public health in their jurisdictions?
It's a bit of a mix. Depends on their resources. We meet with them on a, I think, bi-monthly basis to coordinate resources. Some things they can do, some things they can't. So through contract relationships, we kind of do some shared services, and sometimes we actually do things on their behalf. So it's a bit of a mix. Yeah. Okay. So next slide, please. So one of the slower types of data, for example, are STI, sexually transmitted infections. And this flow chart just kind of shows what happens. A lot of this data is reported directly to the state. The state has to clean it, take out the duplicates. For instance, if you have an STI, you might report to a clinic and get it diagnosed here. A couple months later, you may report to a different clinic or your home clinic. So they got to take out all the duplications, clean the data, make sure it's accurate. They have to deal with that whole residence versus provider location to make sure they're assigning it to the right jurisdiction, because if there's follow-up at the local health department, we have to make sure we're following folks who live in our jurisdiction and versus handing it off to another local health department, et cetera. And then the last piece of this is that there are some data modernization efforts going on at the state, which is going to help us to get the data a little bit faster. The panel down below just kind of shows that we have, it is, as of January, or in January 2024, we finally received the final data set, finalized clean data for 2022. So it kind of gives you an example of the lag. We still have not received the final year-in cleaned, ready to go, validated data from 2023. Next slide. Okay, so what happens, there's a number of different steps in terms of case reporting. A lot of these diseases require reporting directly to the local health department, oftentimes to IDPH. These are the point of service, the folks that are actually seeing the patients, doing the tests. They get the results. It has to be reported if there are a list of these reportable diseases. And then we have to kind of de-identify the patient for confidentiality reasons. And so this chart just kind of shows some of the steps in terms of what happens at the level of reporting versus what happens at the level of notification, when we can get the data set, and then we can then de-identify the data in some cases, and then what we call liberate the data, make it available for the public through our reports, through our dashboards, for them to actually use it to curate and add it to our data, our health atlas, et cetera. So there's a number of steps is the point. What are the time frames? Next slide, please. What are the time frames? So the year ends, the end of 2024, for instance, which is coming up. It might take 6 months, 12, 15 months before that data is finally clean and that data set is closed. What we understand is the further down the timeline after the end of the year, the more and more accurate. There is provisional data. That's one of the things some of the commissioners have asked. What's the data right now? What's the best that you have for us right now? So there's provisional data, but the longer after the close of the calendar year, the more and more accurate that data will become, and then it will be finalized. Next slide. This is a screen capture from the CDC website, which basically shows a highlight here that the STI report for 2022 was just published in January 2024. So it's not just us, it's not a local phenomenon, it's the process of collecting the data, cleaning the data, making sure all the duplicates are out, making sure it's as accurate as possible. If we're going to be making decisions based on it, we want to make sure it's accurate. Next slide. So one of the things we like to do in terms of building healthy communities is to make sure we're making data available. We can't mine all the data, we can't do all the local reports, so we got to make sure folks that we serve have access to the data. So we created something a few years ago, I think about two and a half years ago, called the Cook County Health Atlas. Many of you may know Chicago has a health atlas that's very popular, and we work with them. We're in a work group with them, and ours is basically mirrored after theirs. There's about a 60 or 80% overlap in the indicators that we collect. This is led by our EPI team, led by Dr. Alfreda, and it's a collaboration with UIC, School of Public Health, and Metopia, who is the agent that actually curates data from various different sources, health records, et cetera. We'll talk about that in just a second. So we have data for more than 120 suburbs in this source here, and we're constantly adding additional data indicators. And over the summer, we added about 12 MCH-related data indicators, for example. Next slide. So the Health Atlas has data indicators in all of these buckets. So health outcomes, things around injury and hospitalizations, health behaviors, things around diet, physical activity, sleep, health care, health screenings, et cetera. Things, demographics, like we talked about, very important for framing the health equity questions and challenges, as well as the socioeconomic status and the physical environment, et cetera. So we have more than 100 health indicators, and it allows the visualization, the mapping of the data to inform data-informed approaches to achieving equitable outcomes for the jurisdiction that we cover. Next slide. So I'm just going to walk through a couple of things that this tool, is a very powerful tool, uses. And talk in referring to places, we often kind of segregate into these four different areas here: northwest, southwest, and the south. We can drill down to the zip code, the census tract, and then we are working on what we're calling community briefings at the more local level. Next slide. So an example of stroke mortality, stroke death rate here, and you can see these are directly driven or directly taken from our Health Atlas, put in the queries, and here's what you get. And so again, you can see in the panel to the left by race, these are rates, so apples to apples, and you can see a 60% increase among African Americans in terms of stroke. Looking on the right, you can see trends. This is what, about 10, 12 years trends from 2010 to 2022. And again, you can see the line on the top, which shows blacks, and you can see whites, the blue line, and the red line on the bottom is Hispanics. See, it's all been kind of trending up a little bit recently, dropping among blacks, but you can see that gap, that racial gap in terms of stroke death rates. Next slide. And again, using the heat map, again, you can kind of see where the problem is most dense. So in this case, the heat map, so anything red or orange would be much, much higher rates. And you can see the upper quintiles are in the south and in the west. Next slide. Using another example of preterm birth rate, again, you see that racial disparity, with blacks being about 2 times as high as whites here on the left panel. And then again, you can see the trend, and again, you can see that racial gap, first blacks, then Hispanics, and then whites in terms of preterm birth rate. You can see the trends over time. Next slide, again, looking at preterm birth rate data. This is what we sometimes refer to as the income gradient. It's also synonymous with the education gradient. The more income that you have as you go from right to left, the lower the preterm rates are. Or said another way, the more poor you are, the higher those rates are as well. And the median household income explains about 33.4% of the variation. So again, these are very important trends in terms of our resource allocations, policy decisions, and helping communities to activate around these health concerns. Next slide. So what are some of the opportunities to continue to build in share the data? We have reports, and again, these reports aren't going to be real time for the most part, unless we are actually helping communities kind of mine the data for local community briefings. And again, those may not be completely up to date, but they're very helpful, especially when you look at trends and you look at if they're going up, down, stabilizing, the new demographic groups that are affected or impacted. So we do reports, we do community health plans, something called the Community Health Assessment and Community Health Improvement Plan, which is required for our state certification and also recommended for our national certification, of which we have both. We do this planning with the community and in the community, and it's required every 5 years. Similar to the the community health assessment or community health assessment that many hospitals do. Interactive applications, so I talked about and highlighted the Health Atlas. There are a number of applications and dashboards that we have. The Shiny app that folks might be very familiar with for COVID, those apps are up and active. Today, we created one around Mpox, and as emerging infections or epidemics occur, clusters or what have you, we can mobilize the data to public-facing dashboards, et cetera. And then supporting materials in terms of our web pages, our social media, our infographics, and translating the information and the data into useful tools for folks, because for data's sake, it's not helpful. You have to translate it so it has meaning and folks can actually use it. Next slide. So there's a number of efforts afoot to improve the data availability, increase availability of provisional data. Here's a screen capture from IDPH. And they do have provisional reports. Again, they haven't been finalized, but for some, it's helpful information to kind of see what was the case count over the last month or the last quarter, those types of things. They are undergoing data modernization, which we and many of our associations we belong to are supporting. Adding additional health indicators to our Health Atlas. Again, we're over 100 indicators now, probably close to 140 indicators, and those are growing as there are emerging concerns, public health concerns, and creating more user-friendly dashboards so folks can actually use the data. Also, it's their data. We analyze it, we try to make sense of it, and then we try to make sure it's liberated for folks to use it. Many of these things are available through our website. And then the last slide, I think, just two examples of surveillance data or dashboards that folks can go in and drill down and compare years and trends, et cetera. One, you have the West Nile virus, typically peaks in the summer, goes down, and then we have the epi curve that everybody should be very well accustomed to now for COVID, et cetera. So that is my presentation. Happy to take any questions.
Are there any questions for Dr. Hasbrook on his report?
Dr. Hasbrook, I was at the FD retreat last week, and I heard that there's going to be universal data supplement with IDPH.
Yes.
Do you think that's going to help you get data faster?
Absolutely. Absolutely. So you're referring to the data use agreement with IDPH, and yes, it's going to help us get the data faster. And like I said, there's about 100 local health departments, and every health department doesn't have the same capacity. We, being one of the large ones with an epi team of maybe 6 or 8, have been good data stewards in making sure that we de-identify data, make sure that we're not putting data in harm's way, that kind of thing. So for some health departments, but not all, there's going to be an opportunity to have a relationship where we can get data a little bit more quicker.
One more question about, you mentioned that STI, HIV data are reported based on the provider. I didn't understand why that.
Dr. Kim, can you get the microphone so that people online can hear you?
Yes. So her question was about the slide that that demonstrated that when data is reported, sometimes it's reported at the location, the point of service, so that's where the physician is or the provider is, and then sometimes it's reported by the residents of where the person lives. And so in those cases where it's reported at the level of the provider, what has to happen is there has to be, a reassignment of that case from the, let's say, the zip code of the neighborhood where the provider lives to actually the jurisdiction where they live, because that's how we allocate our resources and our attention.
I mean, that shouldn't be happening, that sort of, you know, like a reportable disease, STI, you know, you actually report the case with the residential address, not the provider.
That is true. That is true. You're going to report all that in the Illinois data surveillance system, the electronic INEDS, or electronic data system, but all that information is reported together. In some cases, it has to be disaggregated. So that's kind of, you would think that automatically it would go in the column of where they actually live, but that doesn't happen. And that's where the additional time takes place sometimes.
Just one more question. I mean, I understand the process and the identification and everything else, but still, like 2 years lag in STD, STI, and HIV reporting, to me, is a little too much.
It does seem a little too much, which is why we spent this 90 minutes with the commissioner, who's brought this up many times in some of these commission meetings, to help kind of walk him through it. Let's just say the end of the year ends, you know, December 31st. So all those cases that are in queue, all the cases that haven't, the physical paper cases that have not been reported, some are reported by form, the mail. Then you got to do the data entry. Then you sometimes got to deaggregate. Let's just say I got my care in Evanston, got a positive STI test, and then 3 months later I went to my local health department, got a positive one over there, same STI, and so now I got 2 in the system. So we have to go through using unique identifying information, make sure we only count that person one time, and then we assign them not to where they got the clinic or the other clinic, but where they actually live, those types of things. So you got the 31st of December, and you have all this time that has to happen to take care of maybe those that came in the last quarter. Those that came in the first, second quarter, they're already cleaned up and ready to go. So it's that kind of time lag that happens. And what we see, and CDC has done a number of studies on this, what we see is that probably when we get to about 9 months after the close of the year, that's when data is about 95% accurate. So that's almost good to go. But if you want to get to the 98% or so, you're going to have to wait probably about 12 months. And we're right on par with the CDC.
Thank you.
Yeah, thank you.
Any other questions for Dr. Hasbrook? Hearing none. Thank you. Thank you, Dr. Hasbrook. We have somebody find Mr. Blakemore? Oh, there he is. We have a, someone for public, an additional person for public comment. Mr. Blakemore?
This is your first day here as the head man of this health and hospital system. I have a long history when Ruth Rothstein was here. So I have an interest in health. Health is wealth. Health is wealth. And the rumor in the Black community is that the quality of health care that the county used to deliver, they're not doing it anymore. Now, I'm one of the citizens that use county care. I've been advocating for years that every employee with this hospital system and every employee with Cook County should use county care. Not where you call from Blue Shield or whatever. Use this hospital. But some of them say it's good enough for the citizens, but it's not good enough for me. So this has been an issue here. So I'm glad that you have allowed me to speak to this body, because you work for the citizen, and you must do more outreach to get more citizen participation. You know, when you call Mr. Blakemore, you're calling somebody unusual. unique and black. So again, I have used the service and I've seen it go down. The emergency room and the various people, it's just all the burden is placed on this system. And Madam President said, we deliver comprehensive health care with dignity and respect for residents. Mr. George Blakemore said, you must deliver comprehensive health care with dignity and respect. First, for your citizens. For your citizens. You cannot serve the world. Several people fly in from India and other parts of Asia and Africa and use this service. You must stop this. It's not good for the citizens. And when I go in to get this service and it's crowded, they should have a line for the citizens and the line for the non-citizens. Because what the citizenship means, it gives me preference. Because I am a legal U.S. citizen. So this is why it's very, very important for a man of Mr. Blakemore caliber to attend these meetings. Mr. Blakemore, you're old. That's strike one. You're poor. That's strike two. And you're black. That's strike three. But I'm still here. And I am somebody. So, sir, you have a great challenge here. Another rumor that's going on in the community is that the credibility that these people that come by, they're getting the county F. So y'all are known worldwide to train doctors. So once the University of Chicago or Northwestern, and you lose your credibility, these doctors going over to those two institutions. They want it.
Excuse me, Mr. Blake.
So again, if my 3 minutes have exceeded, you must be gracious enough to how many citizens did you have here to speak? Sir, you have a great challenge here. Try to reach out to the community and try to get the citizens involved in delivering comprehensive health care with dignity and respect. Take a good look at me and praise about you, and thank you, sir. You have a great challenge here, and I hope you can step up and reach out.
Thank you, Mr. Blakemore. We're now going to move to our next report, which is from our HR committee metrics that Carrie Primavok, our interim chief HR officer, will make the presentation.
Good morning, everyone, and it is still morning, so we're on track, right? But I will go through this because I heard your goal, and since we've exceeded it, I won't try to take up too much time.
Take the time you need.
All right, Carrie Primavok, interim chief human resource officer. So this is our metric slide that shows where we're at with our vacant positions actively being worked in HR. The gold line on the graph on the left shows that we have, as of the end of September, approximately 1,264 of our vacant positions worked in some fashion in the HR recruitment team process. The graph on the right breaks that down into processes. More than 50% of those vacancies are in the interview, selection, and offer stages. And then the number on the far right of that graph, we'll talk a little bit more about on the next slide. So we have there are a lot of numbers up here, but the most important is a little bit smaller. We'll have to work on the font size for the next month's meeting. But we have our positive net gain of 214 positions. That is our net new chipping away at that vacancy number as we account for attrition as well. Our offer acceptance rate is 65% currently. It is down from last year where we were at around 70, 71% hovering. And the national average in healthcare, we're just below the lower end of that number for healthcare. So we are working on multiple process improvement projects and outreach efforts and expanding our networks to ensure that we can get that offer acceptance ratio up. Next is our separations year-to-date report and also our year-over-year. So as you can see, our separations for this year and our turnover has decreased again from 2023, which was a decrease over 2022. So as Dr. Markaitis indicated earlier, that helps us start to really get into that net new positive number where we had 3 years from 2020 to 2022 with significantly negative net gains. And now we're in those positive numbers, and in part that is because of the attrition rate decreasing. Between 2023 and 2024, that is a 15% decrease, and the same thing with between 2022 and 2023. So each year we've been making 15% gains in our attrition rate, making sure that we're retaining our staff and not having as big of a hemorrhage on that side of the equation. Our resignations, as you can see, is our biggest contributor to that. Since 2022, there's been a significant decrease in resignations, but even since last year, we've had a 38% decrease in our resignation number as well. Now, the big month of retirements is coming up in December, so we do anticipate that come January, when we're reporting on this, we're going to see those retirements increase because we're already at steady pace with where we were year over year the last 2 years. And we're preparing for that as well, and as on the recruitment side, as well as anticipating that those numbers will increase during our reporting to you as well. And then the final slide.
Question on retirement.
Oh, sure.
Yeah, retirements are, no, discharges.
They are, yes. We do have, our discharges are up. Some of that is, we broke that down, and some of that is job abandonment, which is some cleanup from earlier in the year and the end of last year for people who fell off of our notice in the rosters, and we're cleaning some of that up. The process that we have to take to get that on off the books takes some time. But then also, the other significant portion of that is performance, and with our increased hiring pushes, we would expect that that is going to increase along with that. So as we're bringing more people on, there is going to be some attrition with those probationary period employees.
Thank you.
Where do people go when they resign?
So we don't have a very significant data source right now of our exit. So we do have an exit survey. It is not well utilized, and so we don't have a lot of statistically significant information to share on that. However, and so most of it is anecdotal, and it is just moving to other systems. People generally aren't sharing with us a lot of that information at present. All right.
Any other questions for Carrie?
I have one. Any indication on what's contributing to the decrease in offer acceptance?
Last year we had a very big push and a couple of new processes that we utilized to increase our hiring rate, and we had a larger database of applicants to pull from at that point in time, so our push was a lot bigger. As and on the next slide it talks about the hiring fair successes, we've still maintained our monthly hiring fair processes. We've concluded the pilot version of our accelerated hiring process. Those pushes, we've seen a decrease in just even the applicant pool, so we're not getting as big of an applicant pool. So our newest endeavor is extending the number of organizations that we are doing those sourcing for applicants as well in response to that decreased acceptance rate. Did that answer your question?
I know we're pressed for time. I
No,
can touch base. Okay.
But we can
So at the point of offer,
Mm-hmm.
so that's the process, the throughput. At the point of offer,
Yep.
The candidate's desired any indication that they're indicating why they're not accepting the offer.
So yeah, we do get some data on that. Again, a large portion of the candidates don't share that, but we do get significant enough to share with us. And so what we're seeing, the biggest salary is usually most on people's mind. It's actually not our highest driver. It's actually our third highest driver. So salary is a component, but it's not the biggest component. Shift, location are often our biggest declines.
Thank you.
Mm-hmm.
Thank you.
What's the second one, just out of curiosity?
Second one is undisclosed. So
Oh, okay.
They don't want to share.
And I think one of the advantages we have is in some areas, our hourly rate, isn't where it would need to be for the industry. But if someone is looking at their overall benefits relative to their hourly rate, you could do very well. You could do very well here as an employee.
I think that is true
The
for.
problem is people don't always do all that package math.
Which we actually, our recruitment team does try to do with individuals, especially if they indicate salary is that point of contention. We walk them through the benefits and how much that contributes to that overall financial package that they're getting. However, what we've noticed doing these market studies that Dr. Markaitis was talking about earlier, that we've been to help us with this, gap in our vacancies and our agency usage, we're finding that our entry-level rates are actually fairly on par, and most of them are actually right at market level. It's when you're incorporating those years of experience into the mix, the step increases on our grades aren't sufficient enough to match that. And so that's what we're looking at right now, is how we can improve that piece of that salary portion.
We were talking about agency use, and I am assuming that's so much more expensive hiring people through that. So are you thinking about like significant improvement in terms of salary offer?
That is a complicated question to answer at this moment. I mean, generally speaking, yes, we are looking at that, but as a general answer. But it gets complicated in how quickly we can do that, as having such a highly unionized workforce. We have to impact bargain that, and then our labor team is moving into successor bargaining, where I'm sure this is going to be a very big topic for us to address.
Yeah, I know that some of the wage schedules and figuring that out were one of the issues that we had during collective bargaining, specifically with one of our significant bargaining units. The interesting thing is where does their original analysis and where they were trying to push us may line up with where we want to go anyway. So we'll have to figure that out. So.
Yeah, one of the interesting dynamics that gets back to this issue of benefits, that may be generational. I mean, if you're young, you want to get your money now. If you're older, you can wait.
That and you benefit.
But it may not be attractive to everyone.
That is true, and we do see that, yes, with the newer graduates into their fields, they don't want to focus, and they don't take into account that financial benefit as much as the straight up salary offers. Yeah. Hiring fairs, just quickly, I'll let you guys peruse the slide just for efficiency's sake, but year to date, we've held 19 hiring fairs. We do these monthly now. Nursing highlights in almost every one of them, most hiring fairs, with the other two big department users of pharmacy and nursing ancillary positions. So such as, medical assistants, surgical techs, things of those natures are also incorporated into our hiring fairs on a very regular basis to try to ensure that we are decreasing agency in those areas as well. And we plan to expand that moving forward. My last slide is our nursing hiring and velocity and attrition slide. This is to help us keep track of where we were with those nursing initiatives, especially around that new accelerated process we began last fall. The two really good numbers up there that I want to focus on are the 157, which is our separations from nursing, which if you compare to year-to-date same time last year is significantly lower, in large part due to the orientation and retention efforts of the nursing team and the engagement they've been doing with the frontline nursing staff, as well as that 98 of net new hires in nursing, which is year-to-date significantly bigger than we were year-to-date with nursing last year at a number of 23. So. And that concludes my report. Any questions?
Separations are down 157 and.
No, we're decreasing from last year.
Okay, gotcha.
Yeah. Gotcha. And then increased our net news in the 98. So the arrows in green show that we are making improvements in the right direction.
Well, yeah, in both of those things, right? So
yep.
When they interact together.
Mm-hmm.
All right, great. next item on the agenda is operational excellence, our OpEx dashboard, which will not be reviewed, but is included in the report for informational purposes in your board packet. Next, we have one item for the closed session of the meeting. So I would accept the motion to go into a closed meeting pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120/2C, 1, 2, 11, 12, 17, and 19. A roll call vote will be needed on this. Is there a motion?
So moved. Second.
Motion's been made and properly seconded. Is there any discussion? All right, will the secretary please call the roll?
Roll call vote on the motion to go into closed session, aye or nay. Director Bott? I believe is absent. Director Burnett Ziegler?
Aye.
Director Garza?
Aye.
Director Green?
Aye.
Director Harrington?
Aye.
Director Kim? Aye. Director Lori is absent. Director Ryder?
Aye.
Acting Chair Ryder, sorry. Director Robinson is absent. Director Sorrell is absent. Director Webster Cross?
Aye.
And Chair Taylor?
Aye.
You have 7 yeas and 5 absent.
Awesome. All right. So we're going into closed session. The only item is to